The next lecture is on the endoscopic treatment of GI neoplasia from ESD to EFTR. So I'm from the Chinese University of Hong Kong with several titles, so I'm currently working I'm also an upper GI surgeon and an endoscopist. So I think from what we know, currently from the global cancer statistics, you can see that the instance of cancer worldwide, commonest is lung cancer, breast cancer, and colorectal cancer. Stomach cancer is number 5, but if you count these stomach cancer and colorectal cancer as a whole, the number of percentage of cancers rate is 16% of all the cancer incidents. While if you look into the mortality, stomach cancer and also the colorectal cancer is among the second and the third most common. And we also know that from the different literature that the survival of gastric and colorectal cancer, it depends on the stage of the diagnosis. So a lot of the time, when we are tackling with this cancer, the most important is how to make an early diagnosis. So if you can recognize early GI cancer, if they are locally situated without lymph node metastasis risk, then the treatment option is endoscopic resection. If there's a local regional disease with a high risk of lymph node metastasis, then we have to treat it by minimal access surgery. The advantage of endoscopic resection, including that this is not only a locally curative intent treatment, but we can preserve the organ so that the functional outcome of the patient is better and with a better quality of life. And it's also a better post-operative outcome with a shorter hospital stay and early return of GI function. In the past, we have already developed numerous methods to achieve endoscopic resection, ranging from polypectomy to EMR. EMR is specially developed to address the treatment of early GI cancer, pioneered by our Japanese colleague. When you look into the technique, it is a modification of the polypectomy with the application of a snare after injection, and also like this is a cap EMR. But the variation, there's a major variation in the recurrence rate locally. One of the reasons is because this technique will be adequate to treat lesions of 1 centimeter. But if for those lesions larger than 1 centimeter, we cannot resect it on block, and we have to separately resect it in piecemeal, and that leads to a higher risk of local recurrence. So that is the reason why our Japanese colleagues pioneer the performance of endoscopic submucosal dissection, or ESD. It can achieve a on-block resection for the local early GI cancer. It can also ensure a wide resection margin with a better specimen for histopathology, and also there may be some differences in the various parts of GI tract in applying this technique, but it can generally be applied for treatment of early GI cancer for the whole GI tract. So this is the first concept of ESD, and reported by Dr. Ono from Japan, and with the performance of a hybrid type of ESD, out of 278 early gastric lesion, local recurrence rate is just 2%. And this is a short video to demonstrate the technique. Also, firstly, we mark around the lesion so that we'll be able to locate. And after the marking, then we inject a submucosal solution to lift up the mucosa and to ensure that we have an adequate submucosal plane for dissection. And of course, with the current optical technology, with the use of the magnifying endoscopy, near focus, and also image enhanced endoscopy, we'll be able to recognize a good resection margin for this lesion. So this early gastric cancer is located at the upper part of the proximal body. So a lot of the time, the dissection will be performed in the retroflex position. So, and you can see that after the injection, sometimes we will not be able to identify a good tumor margin. So that's why we have to mark around the lesion before the dissection. So, and then you can see that we are dissecting at the submucosa. And we are using this ESD device. This is called the dual knife with a water jet function. So when you are dissecting, you will be also able to inject at the submucosa. And during this dissection, a lot of time I would just open around 75% of the circumference before the completion of the submucosal dissection to avoid too much of the leaking effect of the submucosal cushion. So, and some of the area I like to use the IT knife, so insulated tip knife, which is the one of the most earliest type of the ESD device. So it has a ceramic tip to avoid diaphragmatic passage and allow a safe dissection. So, and one of the difficulty of the submucosal dissection is that we do not have another arm or retraction device for us to lift up. So it depends on the cap, the scope, and the technique of the endoscopist to achieve a good lifting effect at the submucosa to avoid a perforation. So this lesion happened to be over a previously dissected area, so over a previous ESD scar. So there may be some adhesion encountered during the dissection. So a lot of time we use the indigo carmine dye to inject at the submucosa so that we can have a better view and avoid a perforation as well. So this is the final part of the submucosal dissection. So after completion of the dissection, we have to re-examine the area and confirm the good hemostasis. So we would also use the coagulation grasper to coagulate any prominent vessel at the ESD site. So there has been meta-analysis comparing ESD versus EMR for treatment of early gastric cancer, showing that there is a significantly better on-block resection rate, lower recurrence rate. However, ESD ended up in a higher perforation and also bleeding. So how about a comparison between the ESD against laparoscopic gastrectomy? So at our unit, we have conducted a randomized control trial comparing ESD versus lap-assisted gastrectomy for treatment of early gastric cancer. So the results showing that the ESD can achieve a shorter operative time, shorter hospital stay, and early return of GI function, and the complication rate is also lower for ESD. And if you look into the post-op pain outcome, that the ESD have a significantly lower pain and also a lower level of CRP on post-op day 1 and day 3. And as I mentioned, one of the disadvantage of ESD is that unlike minimal invasive surgery, we do not have another arm. So we need to use one single arm attached to the scope for the dissection, which is quite difficult. So nowadays, there's been development of kind of retraction device using a dental floss and a clip, so that the dental floss or any suture can be tied to the clip, and the clip will be applied to the edge of the mucosa so that to enhance a retraction. And with this in a reported study, the dental floss group can have a shorter operative time as compared to the control without this retraction. And I think you probably also know that in collaboration with National University of Singapore and also Nanyang Technological University, we developed the robotic master technique for performance of the ESD. So this is a robotic system, and we conducted this clinical trial in India at the Hyderabad at Professor G.V. Rao's unit, and also at the Chinese University of Hong Kong. And with 5 patients with early gastric cancer, we can achieve a endoscopic submucosal dissection with the robotic system. So in the editorial published in the CGH in 2012, actually Professor Halls mentioned that in our report that robotic endoscopy, a small case series, a giant step for endoscopy. So the system has been improving. So this is a second generation of the endomaster EC system. So you can see that there's a well-developed robotic arm, and also a currently independently designed flexible endoscopic platform for the performance of robotic ESD. And after a few animal study, so currently this system is on an ongoing clinical trial at our unit for colorectal ESD. So as Professor Jimmy So mentioned that there is an increasing potential of therapeutic endoscopy. So we can say that this development is actually from the first to the second to the third phase. So you can see, as I mentioned, the very early stage of endoscopic resection is in fact from the concept of polypectomy in 1969. But over the past 40 years, I think there has been a significant improvement in the technology, showed that with the development of EMR, ESD, and the concept of natural orifice transluminal endoscopic surgery, that comes to the second space. Now we recognize the third space, which is the submucosa, and with the poem as a beginning. And this is reported in GIE by Professor Kashyap that if the lumen is historically first space and the peritoneal cavity is known to the endoscopist as a second, then the intramural space comes to represent the third space. So the concept of MIS and also the first space endoscopy, I think there may be some meeting place between the two technology. So I think Professor G.V. Rao will tell us more about that. But with the use of endoscopy over the first space, then we do not need to open up the abdomen with the incision, so that there will be minimal or no pain, there will be earlier recovery, and also no incision, no scar. So I guess next speaker, Professor Anthony Chiu, will tell you more on how EUS can achieve those endoluminal intervention without any scar. So as Professor So mentioned about the first the poem being performed by Professor Inoue back in 2008. So the comparison between these two concepts, I think showing that we are achieving the same surgical procedure and also the outcome, but the poem is without any incision. So, and there's been fast development in the first phase endoscopy. So my talk will be focusing on the endoluminal treatment of GI neoplasia. So at the submucosa, then we are focusing on treatment of a subepithelial tumor. So with the concept of the poem, we can actually pass the scope into the submucosa, and naturally we can encounter this submucosal tumor and treated them by endoscopic resection. So this is called a submucosal tunnel endoscopic resection, STIR, or a peroral endoscopic tumor resection, the POET. So same concept of endoscopic incision, afterwards dissection around the tumor, and thirdly is to resect and take out the tumor, and fourthly is to close the mucosal entrance with clips. So this is one of the diagram to show you the technique of this procedure. So very importantly, step one is to develop a submucosal tunnel. And usually the mucosal entrance is 2 centimeters above the submucosal tumor. And I also always dissect the tunnel around the tumor and reaching the distal part of the tumor. And I need to create a distal pocket so that to allow the manipulation of the submucosal tumor, and finally to take out the tumor from the mucosal entrance site. So this is one of the video to show you how we perform. So it is a esophageal leiomyoma, and we developed the submucosal tunnel 2 centimeters proximal to the tumor, and the same as the poem. Then after dissection of the tunnel, we will be able to reach the submucosal tumor. And after reaching the submucosal tumor, we'll continue the dissection around the tumor, and to ensure that we have a good border of dissection. So this is the submucosal tumor while it is adherent to the muscularis propria layer. And further dissection will be performed around the tumor and to develop a tunnel in the two surrounding. So we used ordinary endoscopic instruments, including, as mentioned before, this is a dual nerve that I also use for performance of ESD. And then afterwards, I would generally also use a IT knife to perform the dissection. So, and you can see, so due to the limited space in the submucosal tunnel, sometimes manipulation of the tumor is quite difficult. So this is the dissection at the base of the tumor from the muscle layer. So as you can see here, so dissecting the tumor away from the muscle layer. Sometimes you need to take part of the muscle in order to get a reasonable margin for the resection. In the esophagus, most of these tumors are leiomyoma, so we are not too worried about the resection margin. But for some mucosal tumor in the stomach, a lot of the time these are GIST tumor. So we are more worried about an incomplete resection with an inadequate resection margin. So after a completion of the dissection, the final part is the most difficult part because most of the tumor is free from surrounding attachment, so making it difficult to manipulate. But finally, we can take this out from the mucosal entrance site and then complete the mucosal closure by clips. This is our report in surgical endoscopy with 51 cases of per oral endoscopic tumor resection. The location of this tumor we selected to be in the gastric cardia, lesser curvature, and from esophagus, because these are the most difficult sites even for laparoscopic surgical resection. Size of the submucosal tumor is usually 20 mm, and the operative time is 90 minutes. So there are some cases that require conversion to laparoscopic surgery, like retrieval, because it is too large a size. And there are 3 cases that I need to convert to full fingers resection. And then there's also 2 cases that require a double entrance and extraction site. But as I mentioned, sometimes it is really worrying, especially in dissecting a GIST tumor, that in the submucosal tunnel resection, we may be breaching the capsule of the tumor, and failure to achieve an en bloc resection will end up in a recurrence for GIST tumor. So I think there are 2 ways to manage that. One is the laparoscopic endoscopic collaborative surgery, while the other is endoscopic full fingers resection. So EFTR has been developed since early 90s with the colorectal surgeon performing transanal endoscopic microsurgery with this TEO device. I think they are doing full fingers resection for early rectal cancer. And the concept is to perform full fingers and afterwards suturing the defect. I think currently it is indicated for mucosal neoplasia that with a dense submucosal fibrosis, making ESD not possible, and also for some mucosal tumor like a GIST tumor. But there are some relative contraindication. For example, if the tumor is too big, then we cannot retrieve it by per oral or per anal route, then this may sound irrelevant to do an endoscopic full fingers resection. And some location may be anatomical limitation, like in the esophagus. If you perform EFTR in a very large defect, sometimes difficult to close. The second is some position in the duodenum, especially in the medial wall. So just to illustrate the procedure step for gastric EFTR. So first, usually this location of the tumor is at the cardia or proximal body for GIST. So firstly, the scope will be placed in a retroflex position. We open up the inferior edge of the mucosa, and afterwards we dissect around the tumor, and with a submucosal muscular dissection for mobilization. And afterwards, we have to apply some retraction device like a clip and dental floss or suture, so that the tumor will be retrieved to the inside of the gastric lumen. So I'm always a believer that the flexible endoscopy performs the best inside the GI tract lumen. So we can achieve this by pulling the tumor to the inside of the gastric lumen, and afterwards we finish the dissection and retrieve the tumor per orally. So this is one of my procedure of EFTR for treatment of the gastric GIST. This gist is located over the gastric proximal body. So as I mentioned, firstly, I would open up the inferior mucosa that is very close to the submucosal tumor. We don't need to develop a tunnel, so we can directly open up the mucosa. And I usually open just half of the mucosa. And afterwards, I would dissect around the tumor. And as you can see, there are the muscularis propria. And because this is a GIST tumor, it can be arising from either side of the muscularis propria, with some component always adherent to the muscularis propria. So I'm pretty sure that we need a good dissection of the muscularis, and all the time ended up in full thickness incision. So I use both the dual knife and also the IT knife for the dissection. And as you can see here, so I also mobilize the tumor, and sometimes cutting the tumor to preserve some of the mucosa to enhance the closure. So this is now full thickness, as you can see. So after the full thickness incision, I always apply the creep and the suture technique. So one of the reasons is because I don't want to drop this tumor into the peritoneal cavity. So if I drop this, then it will be lost, and I need to search it. If I cannot search it, then I need to convert to laparoscopic surgery. So secondly is to pull the tumor to the inside of the stomach, so that I will be able to perform further dissection. So I apply the second. So usually two creep and the suture, and then I pull the tumor further inside. And now with the exposure of the GIST tumor, you can see this is a serosal surface, and they are always having a density of blood vessel over the serosa. But if you can see that, then that is the outside of the gastric wall, and I can pretty sure everybody can understand this is a tumor margin. So pretty sure and confirm that we are not cutting into the capsule, but protecting it. So this technique will enhance the on-block resection of the tumor. And afterwards, I would complete the dissection by using the IT knife. So, and most of the component then be retrieved inside the gastric lumen. So I can complete the dissection from the inside of the lumen. So this is the final part of the dissection. So with the use of the IT2 knife, so I can complete the resection. And then afterwards, I always take out the tumor first, so avoiding it dropping into the peritoneal cavity. So after taking out, I use the Apollo OverStitch, which is an endoscopic suturing device for me to close the defect. So this is the older version of the double channel version of the Apollo OverStitch. So you can see I can pass this needle in between the two arms, and then afterwards I would reload the needle and continue the suturing. So it can achieve a full thickness suturing, so of the two sides of the gastric luminal defect. And after the completion of the suture, we will tie tighten up the suture by using a casing. So now I just drop the needle, which acts as one of the end to pull the needle, while afterwards I will use a casing and tighten the suture. So I usually apply it as a figure of 8 manner for closure, and also I would perform 2 suture, not only 1, because of the safety issue. So, but then after the completion of the suturing, you can see a very definite closure and a good capsule. So if you have a small defect, so one of the methods to use is actually a creep and the loop crown suturing to close. And that's easier to apply, but it's a high demand for endoscopic skill and also need a careful planning. So generally I use a full OverStitch, and it can be divided into single channel, and currently there's also a double channel and also a single channel version of this OverStitch. So we have done more than 22 cases of this endoscopic full thickness resection. Operative time is 92 minutes. The size of the tumor is 21 mm. You can see that half of these cases require OverStitch for closure, and most of these tumors are GIST tumor. So in summary, endoscopic treatment of GI neoplasia has extended from luminal ESD to submucosal resection of this tumor and also EFTR. I think in the future, advanced robotics will further enhance the development of endoluminal therapy for GI neoplasia. So with that, I hope to welcome everyone to join us, and I hope it will be a physical meeting for ELSA 2021 in Hong Kong.